Good. All right. For today's session, we'll be looking at patient assessment. Yesterday, we looked at airway management. That's module 4. Today, we're going to be looking at patient assessment. This would be module 3. This is a very long chapter, might be as long as the airway chapter in your textbook. Very important chapter. So it's equally important as the airway chapter. Once you're going to perform any type of patient interaction, you're required to have a sequential approach to assessing your patient, assessing and treating the patient. The patient assessment chapter outlines a sequence that you will follow in order to assess your patient. Now, every EMS provider will ultimately develop their specific approach to assessment or assessing a patient, but it will follow the fundamental principles of this chapter or module, patient assessment. So let us get right into it. Right. Oops. All right. So patient assessment is very important. EMTs must master the patient assessment process. Patient assessment is used to some degree in every patient encounter. So regardless of whether it's a medical or trauma patient, you will have to perform some type of patient assessment. Now, there are 5 main parts of the patient assessment. You have a scene size up, you have primary assessment, you have history taking, secondary assessment, reassessment. 5 main parts. Each of these parts have specific things that must be considered or executed. Right? So you must know the 5 parts, you must know the various things or procedures that must be considered for each part. Yes, Mr. Wilson.
Sir, I'm not seeing the screen, sir.
That would be a problem on your end. Anybody else having issues seeing the screen?
No, sir.
Okay. So that's a problem on your end, Mr. Patrick Wilson. You need to figure that out on your end. So even though there is 5 parts, well, all the 5 areas are important. One of the most important area of the patient assessment algorithm is the primary assessment. So the primary assessment is extremely important because this is where you will identify and manage life threats or manage things that can kill your patient. And this is where you will make contact or interact with your patient, the primary assessment. Now, rarely does one sign or symptom show you the patient's status or underlying problem. Right? So we learned this by now. We don't focus on one specific finding. We look at the patient presentation, look at the numbers, we put them together and consider what is going on, what we need to do for the patient. Right? So symptom, subject, condition that the patient feels and tell you about. So you need to know the difference between a sign and a symptom. The symptom is going to be subjective. So this is based on what the patient tells you, right? If the patient says he's having a headache, chest pain, difficulty breathing, pain in the eyes, these are symptoms. Now, a sign is based on your observation. So the sign is going to be based on your observation. So it is what you see, what you smell, what you hear, and what can be measured. What you see, smell, hear, and what can be measured. That's a sign. Now, the first section of the patient assessment algorithm is scene size up. Now, within the scene size up, you have to check to ensure that the scene is safe. You have to take standard precautions for yourself and your partner. You need to consider the mechanism of injury or nature of illness. You need to consider if you have more than one patient to deal with. You need to determine if you need additional resources. And based on the mechanism of injury, you need to determine if you need to take C-spine precautions for your patient. So this is the first section, scene size up. Your evaluation of the conditions in which you will be operating. Maintain situational awareness. Scene size up combines an understanding of the situation and conditions prior to responding. You will consider the information that you get from dispatch. You need to observe your scene carefully. So the first thing within the scene size up is we need to ensure that the scene is safe. Issues can range from minor difficulties to major dangers. Do not enter until the scene is safe for you and your team. Typically, the way you enter an area is the way you will leave. Wear high visibility safety vests on roadways. Things that you need to consider when ensuring scene safety. Consider difficult terrain. Will you need specialized rescue equipment or a specialized rescue team? Consider the flow of traffic. If it's a motor vehicle accident, do you need to create a visible barrier for traffic to realize that they can't come close to that area? With the environment, you need to consider if whatever is happening in the environment is affecting you. In other words, if the environment is too cold or too hot for you, it's going to be the same for the patient. If appropriate, help protect bystanders from becoming patients. Hazards range from extreme weather conditions to threat of physical violence. An emergency scene is a dynamically changing environment. If the scene is unsafe, make it safe if possible. If this is not possible, move to a safe location. Now, thinking about scene safety, what are some of the things that can be found on a scene that will make that scene unsafe? Mr. Zandre Powell, quickly.
Downpour lines.
Okay.
In terms of like a motor vehicle accident, you can have possible fire from spilled gasoline and stuff like that.
Okay, so I heard dangling power lines, gasoline from a MVA. Miss Wellington, if there is a power line that is dangling, who would be responsible for that?
The fire service, sir.
Not responsive. What was that?
The fire, so the power service, sir.
The power company, yes. No, apart, yes, you're correct. Mute your mic. Mr. Manning, if there is oil spill from the motor vehicle accident, hazards for fire, who would be responsible for that?
That's when you would call the fire department.
All right, so that's when the fire department would be considered. Outside of dangling power lines, gasoline spillage, fire hazards, what other type of hazards can be present on the scene that would make it unsafe? Yes, Mr. Smith.
Yes, sir. Smith here. So dangerous fumes, sir.
Fumes.
Yeah.
All right. Mr. Terrell, if there is toxic fumes present on the location, who would be responsible for that?
Fire brigade, sir.
That's too vague. Fire brigade is not responsible for toxic fumes. You need to be more specific.
Fumes department.
Yes.
Morning.
Morning.
Johnson here.
Yes.
We have any like specialists in a biohazard, like if we have a biohazard leak, and we have a special unit in Jamaica for deal with that?
A special unit.
Yes, like the chemical business.
There is NEPA. And
Never.
within the fire brigade, you have hazmat.
That we never sure about that still, cause that's why I may ask you about it.
Okay.
All right.
Sir, we actually I discussed that,
Okay.
the hazmat aspect, but never sure if we have any.
It has to be a hazmat team.
Okay,
Hazmat
sir.
team.
Okay.
All right. So the principle is once you identify a hazard, you need to determine what would be the most appropriate response to that hazard, whether it is the fire, hazmat, whether you need the police. One of the most unpredictable hazard you'll have on any scene is going to be people, especially in Jamaica. So you're gonna need crowd control, and when we start to talk about crowd control, that's when law enforcement gets involved. An emergency scene is a dynamically changing environment. If the scene is unsafe, make it safe if possible. If this is not possible, move to a safe location. That's straightforward. Now, so the first phase of your scene size up is ensure that the scene is safe. Then you will consider the mechanism of injury or the nature of illness. I have already explained this to some extent. So the mechanism of injury is whatever caused the injury, and injuries result from forces applied to the body. When force is applied to the body, if the body cannot dissipate, so if the body cannot spread that force out, the force becomes concentrated, and that results in soft tissue injury. So the mechanism of injury is whatever caused the injury to the patient. Was it a fall? Was it a gunshot? Was it a motor vehicle accident? Was it from blunt force trauma, from a physical assault? Whatever caused the injury to the patient. And that mechanism can be diffused or it can be localized. So an example of a localized mechanism would be somebody's going down a stair, not paying attention to what they're doing, lose their balance or slip, twist the ankle, catch the railing. So they twist the ankle, catch on to the railing that they don't fall. They start to have pain in the ankle. That would be a localized mechanism. The injury is specific to the ankle. That's localized. On the other side of that, somebody is going down a stair. The person lose their balance, miss the railing, roll down the stairs, lick them head, end up at the bottom of the stairs. May or may not be responsive. The possibility for multiple trauma now exists, so the mechanism becomes diffused. Once you have a diffused mechanism, you will suspect spinal injury until it is ruled out. So the mechanism of injury, you will consider the type or amount of force involved, where that force was applied to the body, and you will consider what type of structures are found in that area of the body and what are the function of these structures. So calls for assistance can be categorized as medical conditions, traumatic injuries, or it can be a combination of both. A medical problem can lead to a traumatic injury, and a traumatic injury can lead to a medical problem. Fragile and easily injured areas include the brain, spinal cord, and the eyes. Now, the mechanism of injury, the force involved, is divided into blunt force trauma and penetrating trauma. Later on, I'll add another one to that when we cover trauma overview. Blunt trauma, the force occurs over a broad area. The skin is usually not broken. Tissues and organs below the area of impact may be damaged. For penetrating trauma, the force of the injury occurs at a small point of contact between the skin and the object. Open wound with high potential for infection. All right, now when we start to talk about the nature of illness now, so the mechanism of injury is specific to your trauma patient. The nature of illness is specific to medical patients. So this is the medical patient's chief complaint, whatever the patient is complaining of. Difficulty breathing, chest pain, severe abdominal pain, severe headache with nausea. Right? So whatever the patient complains of is the chief complaint or nature of illness. Now, this information, you can get it directly from your patient. You can get the nature of illness from the patient. You can get this information from family members, and you can get this information from bystanders on the scene. If you're in a situation where you cannot clearly find out what is the chief complaint for your patient, so if you're in a situation, in which you cannot clearly find out what's the issue for the chief complaint. Ensure that you evaluate the patient's pupil response to light. You check the patient's blood sugar, and you evaluate the patient's pulse oximetry reading. You need to look at the patient's pupil reaction with a pen light. You need to check the blood sugar. Is it high? Is it low? Is it normal? I need to look at the oxygen level in the blood. Is it normal? Is it too low? Is it too high? Is this patient getting too much oxygen? Be aware of scenes with more than one patient with similar signs or symptoms. Usually, when that occurs, you have a hazmat situation. When you have multiple patients with similar signs and symptoms, you should be thinking, okay, we might have a hazmat situation. No, we need to get as far away from this scene as possible. Should be so far away from the scene, you need a binoculars to see the particular scene. Example, carbon monoxide poisoning could indicate an unsafe scene for the EMTs as well. And carbon monoxide loves your red blood cells love carbon monoxide more than it loves oxygen. So once it is inside of the body, it will pick, the red blood cell will pick up that instead of the oxygen molecules. And that can kill a patient. Importance of MOI and NOI. Considering the MOI or NOI early can be of value in preparing to care for the patient. You may be tempted to categorize the patient immediately as either trauma or medical. Fundamentals of good patient assessment are the same. So whether or not you can determine if you have a medical or trauma patient, both patients will get a primary assessment. So your fundamentals will always be the same. You need to check the patient's level of consciousness, check their airway, upper, check lower airway, ventilation, oxygenation, respiration, check circulation. Is this patient bleeding? What is the skin color? What is the pulse? What's a cap refill? Right, so the fundamentals will always be the same. Right, so we have looked at ensuring the scene is safe. We're still in scene size up, So 1, ensure scene safety. 2, consider the mechanism of injury or nature of illness. 3, take standard precautions. Wear PPE. And this used to be referred to as take BSI precautions, the same thing. So wear personal protective equipment. Should be adapted to the pre-hospital task at hand. Standard precautions have been recommended for use in dealing with objects, blood, body fluids, other potential exposure risk of communicable diseases. And the assumption is any fluid that is coming from the patient is considered contagious. So you will always ensure that at a minimum you have on your gloves and keep additional gloves in your pocket, especially if it's a trauma scene with a lot of blood. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. At minimum, gloves must be in place. Consider glasses and mask. Now, I don't put on my gloves inside of the unit. Right? I'm not gonna put on gloves. I'll have gloves in my pocket. I'll have my goggles on my head. It's not over my eyes at that point, on my head. I put on my gloves when I am approaching the patient. So I'm not gonna put on a gloves, open the ambulance door, come out of the ambulance, walk towards the patient, home, touch the area, touch the door and open the door with the gloves. That's a dirty gloves now. So I put on my gloves when I'm about to make contacts. As I'm communicating, where's the patient, I'll put on my gloves at that point. So that's standard PPE. So one, ensure the scene is safe. Excuse me. Ensure the scene is safe. That's the first one. Consider the mechanism of injury. Take standard precautions. Identify how many patients you have. So do you have one patient? Do you have more than one? Why is this important? So during scene size up, accurately identify the total number of patients. Critical in determining the need for additional resources. When there are multiple patients, use incident command system, identify the number of patients, and then begin triage. So if it's one patient, then easy. Just do what you need to do. If it is multiple patients, then you need to consider if you have patients that exceed what you can do. Right? So is there multiple patients on their chief complaint? You don't have the resources to deal with the situation. Then it becomes a mass casualty situation. Once it becomes a mass casualty situation, if you are the first unit on scene, if your unit arrive on scene, your goal is going to be to triage. Triage means to sort. It does not mean to treat. A lot of persons tend to not understand that. Triage means to sort patients. It does not mean to treat. So what does that mean really? It's simple. If there's a mass casualty situation, and let's say all of you inside this group is involved, and the first person I come across, or the first person that I would make contact with or come across, is Zandre Powell, right? So when I arrive on scene, he's the person that is closest to me. But when I look down the line, I can see that Mr. Cameron's arm has been amputated. So I can see that Mr. Cameron's arm has been amputated. So the question is, do I bypass Mr. Powell and go down to Mr. Cameron to treat him? That's a question. Anybody have a response? Yes, Mr. Michael Wilson, go ahead.
Bypass Powell because Cameron, there's a threat that Cameron going into chat because he might lose blood.
And that would be incorrect. That's the point I am making. There's a difference between triage and treating a patient. The goal of triage is to save as much persons as possible, not to save one person. Right? Now, why am I going to bypass Powell, Wellington, Manning, Tyrrell, Patrick Wilson, Michael Wilson, Miss Lewis, George to get to Cameron? What happened to the people that in the middle? To save one person? So that's the difference between triage and treating a patient. So what would happen is, if I come on the scene and it's a mass casualty situation where there's multiple patients involved, I'm going to get on my microphone. I'm going to identify my unit. This is Ryan Rufus, I'm a paramedic. This is Unit 20 from MedStar. Other units are on the way. Fire is on the way. If anybody can hear me, you can hear me clearly. If you can stand and move, I want you to stand and go to the tree to my right. So go to the tree to my right. I'm not going to tell those persons to come to me. No, all of those persons that stand up and can move, that's your walking wounded, like just triage a whole heap of people. So while these persons are walking to the tree to my right, I look. Hey, you. Yes, you, sir. You, sir, in the black shirt. You in the white shirt. Come this side for me. I might need your help. Right? So that's the first phase. Now, when I get to the point where I need to start the triage process now, a more intricate triaging process, I will start where I stand. So the first person that I make contact with is Powell. So Powell will be the first person that I triage. Even if Mr. Cameron, by the time I get to Mr. Cameron, he's dead. That is triage, right? So when I triage Mr. Powell, I am not doing a typical assessment. I'm going to be looking at a couple things very quickly. Does he seem to be breathing? Is he breathing? Is it fast? Is it slow? Right? That's the first thing I'll look at. Now, if he doesn't seem to be breathing, I will attempt to position his airway. After I attempt to position his airway, if he doesn't start breathing, I tag Powell as dead and move on to Miss Wellington. That is triage. Everybody understand that concept. Good. So triage is not treating, it is sorting. Now, let's say I position Mr. Powell's head and he starts breathing. I can now tell the guy, hey, you come here, you in the block. Keep his airway like this for me. Just keep it like this. And then I would tag Powell as red. That's critical. So that means as soon as other units are available, he has to be transported as soon as possible. Right? So with triage, we look at three things: respiration, perfusion, mental status. When it's one patient, we look at level of consciousness, airway, breathing, circulation. And as we find issues, we fix the problem and we won't move on to anybody else. We focus on that individual patient. So ensure that you understand that difference. Because a lot of persons in Jamaica has touted that they have done not hazmat, they have done mass casualty course. When you ask them a simple question like this, or give them a scenario like this, they don't know what to do. So triage is sorting, doesn't mean to treat. Remember that. So triage is the process of sorting patients based on severity of each patient's condition. Some situations may require more ambulances, some may require specialized resources, hazmat. So specialized resource, that's the next phase. So we have looked at, so scene, when we're doing a scene size up, ensure the scene is safe, consider the mechanism of injury or nature of illness, take standard precautions, identify how many patients, if it's more than one patient, do you need to initiate triage protocols. And of course, you're going to consider additional specialized resources. So specialized resources include, do you need ALS response? So based on your assessment of the patient, is BLS needed? Do you need air medical support? Do you need fire, who may handle high angle rescue? So is it fire, but you need a specialized rescue team? Or is it fire and you need a hazardous materials team or hazmat team? Or do you need water rescue? And of course, law enforcement. To determine if you require additional resources, ask yourself, does the scene pose a threat to me, my patient, or others? How many patients are there? And if you have more than one patient, does it exceed your available resources? Do we have the resources to respond to their conditions? So do you have the resources that you need? Right? And that's the scene size up. So before I move into the primary assessment, is there any questions on the scene size up? Okay. All right. So let's see, going up the line. Mr. Patrick Wilson, what's the first thing you consider in your scene size up? Sorry?
Hello?
Yes.
Yes, sir.
What's
Right.
the first thing you consider in the scene size up?
The amount of patients, that you have on the scene, sir.
Mr. Patrick Wilson, I'm gonna ask you a
Yes, sir.
serious question now. Very serious
Yes, sir.
question. Think about it carefully before you respond. Are you paying attention to the lecture?
Yes,
You sure?
yes, sir. But some of the time I have a little bit of difficulty with the audio.
Okay. Mute your mic. Listen. What's the first thing you will consider in your scene size up? Good. Things that can make the scene unsafe. Still on you, Mr. Wilson.
There are like down power lines. If fumes involve like hazardous material, I have to call like a hazmat team.
Anything else?
Also, there are oil spills which can potentially cause fire and local fire brigade.
Anything else?
Also, if it's like violent circumstances, the patient get injured and police are involved, like if it's a domestic case.
Police is not only involved in domestic cases. Crowd control, that's the police responsibility. So law enforcement has that responsibility. And crowds can be very unpredictable. You need to ensure that you're thinking about that in a scene size up. All right. After we have ensured that the scene is safe, what else we need to consider?
The mechanism,
What?
mechanism of injury.
Mechanism of injury. Your understanding of the mechanism of injury, Miss Lewis?
My understanding from that is the amount of force that is applied to cause an injury.
Okay. Which patient would that be specific to? Trauma or medical?
trauma patient.
Okay. All right. Mr. George, outside of scene safety mechanism of injury, what else must be considered in the scene size of phase?
Yes, sir.
Number of patients.
Triage, sir, and consider additional specialized resources.
When would you need to consider triage?
If you multiple casualties, sir.
We don't use the term casualty in EMS.
All right, sir. If you have multiple patients, number of patients.
Multiple patients, and I have multiple patients. Yes, they are present. How do I determine if I need to triage?
In like a motor vehicle accident.
Put your mic. All right. So, yes, Mr. Cameron.
Could you tell why we don't use the word casualty in EMS, please? We repeat.
What is your understanding of the word casualty?
Person suffering from an illness.
A person who suffers from?
Any form of illness or injury, sir.
A person who suffers from of illness or injury?
Or, yes, sir.
Where would I find that information?
Well, it's my interpretation, sir. My layman's interpretation.
All right, so get the correct information and then we can have that conversation. But we're not gonna have that now. It's not relevant to what I'm teaching. So if you want to have that discussion offline, that's fine. Not relevant to the topic at hand. Yes, Mr. Wilson.
Sir, for the when you ask about the respiration, perfusion, and did I say one third thing, circulation?
We'll get to that.
All right.
Talking about the triage process, I thought you were talking about the individual assessment. So with triage, you look at respiration, you look at perfusion, which is bleeding, skin color might not be for all cases, and mental status.
Okay.
And perfusion, mental status. If it's one patient, you look at level of airway, breathing, circulation.
Okay, sir.
All right, so let's move on to the next phase, primary assessment. Begins when you greet your patient. The goal is to identify and initiate treatment of immediate or potential life threats. So the primary purpose of your primary assessment is to identify potential and immediate life threats and correct these life threats. So there are specific things that you need to be looking for, and I've mentioned this before. So a patient with a closed airway, that can kill them very quickly. A patient in which the chest is not moving, that can kill them very quickly. A patient that is bleeding excessively, that can kill the patient very quickly. So these are things that you should be looking out for. So your assessment, your primary assessment, need to be focused on those things. So you're going to be looking at the nervous system, respiratory, cardiovascular system. So it begins when you greet your patient. That's when it starts. The goal is to identify and initiate treatment of immediate or potential life threats. Physically examine the patient and assess level of consciousness, airway, breathing, circulation. So the first thing, so just like the scene size up, where you have to ensure the scene is safe, you have to consider the mechanism of injury or nature of illness, you have to take standard precautions, you have to identify how many patients you have to consider the need for additional resources. It's the same with your primary assessment. So there are things that must be considered, there are things that must be assessed. And the first thing that you need to consider is the general impression, which you're doing a visual assessment. So when you form a general impression of your patient, it's a visual assessment. What does that entail? So you need to answer two questions when you're forming a general impression. And the two questions are, does this patient look sick or injured? Does this patient look sick or injured? And based on that answer to that question, the next question is, how sick or badly injured is this patient? That's the two questions. So you'll be looking at the patient's age, sex, race, position, level of distress, overall appearance. These are things you're going to consider. So note the patient's position. What is the position of your patient? Is this patient standing, sitting? Is the patient face down? Is the patient lying supine? Avoid standing over the patient. Address the patient by name, introduce yourself, ask about the chief complaint, address life threats immediately. Determine the patient's condition. So based on your general impression, you'll be able to decide, okay, is this a possible stable patient? Is it a stable patient, but the patient has a condition or injury that can make them unstable? Or is the patient unstable? Now, after you form your general impression, and when you form a general impression, or move on to the LOC, it is not specific just to the patient. So you're going to look at the environment. You look at the patient, you look at the environment that you find the patient in for clues that could give you indicators as to what is the medical issue or what caused the injury to the patient. So you look at the patient. Is it an adult male, female, right? Is it a geriatric patient? Is it a pediatric patient? Where you find the patient? What is the position of the patient? Right? What is the level of distress? Is there any life-threatening injuries or hemorrhaging present? All of these are things that you would consider or be looking for in your general impression. So after your general impression, so after you form your general impression of the patient and the environment in your primary assessment, the next step would be to ascertain the patient's level of consciousness. So the level of consciousness can tell you a great deal about the patient's neurologic and physiologic status. So the very first assessment focuses on brain function. Now, assess level of consciousness. Your patient can be unconscious. Your patient can be unconscious with an altered, your patient can be conscious with an altered level of consciousness. Right? So the patient might be conscious, but they are disoriented or confused. The patient can be conscious with an unaltered level of consciousness. So the patient can be conscious and fully oriented. The person, place, time, and event. Now, assessment of an unconscious patient focuses on airway breathing and circulation. Sustained unconsciousness should warn you of a critical respiratory, circulatory, or central nervous system problem. Conscious with an altered level of consciousness may be due to inadequate perfusion. Perfusion is the circulation of blood within an organ or tissue. Right now, outside of perfusion problems, it could be linked to medications. So the patient's level of consciousness can be affected by medication, it can be affected by drugs, it can be affected by alcohol or poisoning. To assess for responsiveness, you're going to use the mnemonic AVPU or AVPU, awake and alert. And when we look at whether your patient is awake and alert, you need to also consider your level of orientation. Are they oriented to person, place, time, and event? Is it that the patient is only responding to verbal stimuli? That's what the V represents. Is it that the patient is only responding to painful stimuli? That's what the P represents. Is the patient unresponsive? That's the U. Once your patient is unresponsive, the muscles that control the tongue will relax and the tongue obstructs the ear passage. You now have an airway problem. This is something that can kill your patient. Now, areas that you will consider checking for pain, it can be pinching the earlobe, pressure on the, they can be pinching the earlobe, pressure on the supraorbital nerve, pinching the neck, pressure on the cuticle of the nail, and in extreme circumstances, you can attempt a sternum rub, but make sure you consider the history of the patient and the gender as well. Now, again, once you're going to look at whether your patient is awake and alert, you also need to check the patient's level of orientation to person, place, time, and event. The patient must be able to tell you who they are, must be able to tell you where they are, they should be able to tell you what time of day it is, which day it is, which year, and they should be able to tell you exactly what's happening to them. If they are not able to answer all of those questions appropriately, then your patient cannot be fully oriented. Now, it is asked in this order: person, place, time, event, to ascertain long-term, intermediate, and short-term memory. So this will evaluate long-term memory, intermediate, and short-term. Altered mental status is any deviation from alert and oriented to person, place, time, and event, or any deviation from the patient's normal baseline. What does that mean? So if the patient is is said to be behaving outside of what would be normal for them. In other words, if there is a deviation in one of these areas, you need to find out, if possible, is this the norm, right? Because their ability to respond to these questions can also be affected by their level of education, right? You can have communication barriers because they don't speak English, right? So you need to find out, if possible, it might not be possible in all cases. If somebody is there that know the patient, is this how this patient normally behave? Is this normal for this patient? Right, now identify and treat life threats. That's the primary goal of your primary assessment. Identify immediate and potential life threats. Things that can lead to sudden death. Airway obstruction, respiratory failure. Mr. Powell, Zandre Powell, what would you consider to be respiratory failure? What are you looking for? Quickly. Two things that you would focus on. Yes, Mr. Cameron, go ahead.
So respiratory failure is the result of inadequate
Inadequate breathing.
cyanotic coolant.
Yeah, chipping in and out.
I hear me now, sir.
Yes, better.
Yes, sir. Respiratory failure.
All right, you have to go wheel and come again.
Um,
You have to, I can't hear you. You're chipping in and out. You're chipping in and out. Yes, Mr. Powell.
So you're looking for things like adequate chest rise, rate, rhythm, and the patient's level of consciousness as well.
Okay. But I am asking, what are definitive findings? So you're going to consider all of that. But there are two things. If you see it present in your patient presentation, you know for sure, without any doubt, that this patient is going into respiratory failure. Anybody know that those two things that you would be looking out for? Mr. Cameron? Yes, Patrick Wilson. Go ahead.
The amount of breath the patient is taking, sir, per minute, and the level of consciousness in which the patient is in at that present time, sir.
The level of consciousness is one. Amount of, what you say, the amount of breath?
Yes, sir.
I would prefer you say volume or poor chest rise. So yes, you would consider the level of consciousness, and you're looking at whether the patient has visible chest rise. If the patient has poor chest rise, that's failure. Right? So poor chest rise with an altered or decreased level of consciousness are positive indicators of respiratory failure. You know for sure the patient is failing. Respiratory arrest. This one is pretty straightforward. What are we looking for to determine that a patient is in respiratory arrest? One to answer that one. Yes, Mr. Zandre Paul, go ahead.
The patient isn't breathing.
That's correct. So the patient stopped breathing. Now, Mr. Zandre Paul, if the patient had agonal gasps, how would you view that?
Still considered as not breathing, sir.
Okay. All right, good. All right, so conditions that cause sudden death: airway obstruction, respiratory failure. Remember, two key findings: decreased level of consciousness or chest rise. Area arrest. Miss Lewis, mute your mic. Area arrest. Patient stop breathing. If you observe agonal gasp and your patient is unresponsive, that's not considered breathing. Is the patient going into shock? Is there severe bleeding? And primary cardiac arrest. No, in most cases, begin with airway followed by breathing and circulation. So in most cases, that's how you're gonna approach. However, there are some exceptions or considerations. So if there is signs of excessive bleeding, then your assessment becomes XAB or CAB. X would be representative of exsanguinating bleeding. So the patient is at risk of bleeding out, right? So if the patient is bleeding excessively, you have to control that significant blood loss, then go into your LOC, airway breathing circulation. You're still going to be doing circulation because when you control blood loss at that point, that's just one aspect of circulation. So you still have to complete the other checks in circulation down the line. So that's one instance where your assessment approach will change. Now, if it is a patient that is in cardiac arrest, when you did your BLS course or CPR course is CAB, right? Now, in field practice, simultaneously, right? So in field practice, we simultaneously position the airway and check for the pulse at the same time, right? If there is no obvious signs of breathing. So it's simultaneous positioning and check. So those are some situations in which your assessment would change from ABCs to CABC, right? Excessive blood loss, patient that is showing signs of cardiac arrest. All right, now, once you have completed your level of consciousness assessment, so the first thing you evaluate in your primary assessment is a general impression of the patient and the environment. Then you will ascertain the patient's level of consciousness using your AVPU. Based on the findings for your AVPU, is there any life threats present? So based on the findings for your AVPU, are there any life threats present that requires immediate intervention? After the LOC, then it's airway assessment next. Right, so moving through the primary assessment, stay alert for signs of airway obstruction. Ensure that the airway remains open or patent and adequate. Responsive patients, patients who are talking or crying, have an open airway. Watch and listen how the patients speak. If you identify any airway problem, stop the assessment and work to clear the patient's airway. If a patient is talking to you, don't tell me say you go position the patient's airway. The patient is communicating, right? If the patient is not responsive, then naturally you will have to position the airway. If the patient is semi-responsive, then you have to position the airway. For unresponsive patients, immediately assess the airway. Use a jaw thrust technique when necessary, and that would be for your suspected spinal injury patient. Use the head tilt chin lift technique when necessary. That's for a patient that you suspect has no spinal injury. Relaxation of the tongue muscles is a cause of airway obstruction. So that's the first thing we must consider in an unresponsive patient. Now, signs of obstruction in an unconscious patient. Obvious trauma, blood or obstruction. Noisy breathing. Is the patient snoring? That's the tongue. Bubbling, gurgling sounds, that's fluid. Throwing, upper airway issues. Abnormal sounds, it can be wheezing, can be bronchi, can be rales, which are both crackles. Is the patient breathing extremely shallow or absent breathing? Which would be a ventilation problem. So if your patient is breathing shallow or there is an absence of breathing, that's definitely a ventilation issue. Now, if the upper airway is fine, the next thing that we need to look at is the lower airway. And when you're looking at the lower airway, you're thinking about ventilation, you're thinking about oxygenation, and you're thinking about respiration. So make sure the patient's airway is open. Make sure the patient's breathing is present and adequate. Ask yourself, is this patient breathing? Is this patient breathing? Is the patient breathing adequately? Is the patient hypoxic? Now, which bright spark can tell me what are the things that we are going to check in breathing to determine that this patient is breathing adequately? So what would your breathing assessment entail? If it's upper airway, we position, we check if it's clear, we look, listen, and feel. Full stop. If it is lower airway, what does your breathing assessment entail? Any takers? Mr. Powell.
Yes, sir.
I'm listening, go ahead.
For adequate breathing, sorry, I'm checking for the correct rate, depth, regularity.
Rhythm.
Yes, sir. And
anything else?
rate, rhythm, rate, depth, regularity.
Rate, rhythm, quality, depth. That's it. Right? So the rate, no, it's not just telling me what you're looking for. You need to know what it means. What exactly are you looking for? Don't just tell me rate, rhythm, quality, and depth. You need to demonstrate to me that you know what that means. So rate, you're checking to see if it's fast or slow, or if it's within normal range. Yes, Mr. Johnson.
Yes, Chief. As I said, the rhythm or the breathing, you know, look, the rhythm will deal with the consistency or inconsistency of the breathing.
Right.
All right. So then you have now the bilateral movement of the chest.
Category that falls in.
It expand while
No, man. What I'm asking is
how much that expand.
Which category would it fall in? Is it rhythm, quality, or depth? So when you're looking at chest rise, where does that fall?
Sir, can you repeat that, please?
When you're looking at chest rise, is it rate, rhythm, quality, or depth? Yes, Mr. Patrick Wilson. What's going on there? Go ahead.
Hello?
Yes, go ahead.
So you said rhythm or depth, it will fall in depth, sir.
Depth, right? So once we're looking at chest
Yo,
rise, that will be
what are
considered
the
depth.
game?
Mute your mic, young man. Mute your mic.
No, come on, you know.
Oh boy, let me do it for you then. Right, so rate is how fast or slow the patient is breathing or whether it is normal. The rhythm is consistency. Does it speed up and then slow down, or is it constant? That's rhythm. Quality is specific to position. So quality is position. Quality is abnormal sounds. Quality is so quality is position, abnormal sounds, and muscle use. Right? So quality is position, abnormal sounds, muscle use. The chest rise is depth. You're looking at depth. You're trying to determine if your patient has good tidal volume. So we look at rate, rhythm, quality, and depth. Now consider providing positive pressure ventilation with an airway adjunct when the respiration exceed 28 breaths per minute or is fewer than 8 breaths per minute. However, there must be associated symptoms because we don't only treat rate, right? So if it's very fast, are there associated symptoms? If it's slow, are there associated symptoms? That tells me that I need to provide positive pressure. So the goal for oxygenation for most patients is an oxygen saturation of approximately 94 to 99%. So assess breathing, observe how much effort is required for the patient to breathe, look for retractions, use of accessory muscles, right, in the neck and in the chest area, nasal flaring, 2 to 3 word dyspnea, so is a patient pausing to catch their breath while they speak to you. That's referred to 2 to 3 word dyspnea is also known as staccato speech. Is there tripod positioning? Is there sniffing position? Is there labored breathing? Respiratory distress, increase work of breathing, increase effort and rate. That's respiratory distress. And if it is mild or moderate, the mental status or level of consciousness should not be affected or altered. If it is severe respiratory distress, let me rephrase that. If it's mild or moderate respiratory distress, the mental status or level of consciousness should not be affected, and your patient should have visible chest rise bilaterally. If it is severe respiratory distress, the mental status or level of consciousness will decline. Breathing rate might still be going up, or you might see it come down to normal levels. The patient will be working extremely hard to breathe. You can still see chest rise bilaterally at this point. That's why it's still classified as distress. If distress is not corrected, so for mild and moderate distress, you give supplemental oxygen either with your nasal cannula at low flow or partial rebreather or non-rebreather for high flow. if your patient is showing signs of severe respiratory distress, then you need to be prepared to provide positive pressure with either a pocket mask or a BVM device. In respiratory failure now, so if respiratory distress is not corrected, the patient's chest rise will decline. So you're looking for a change in the patient's level of consciousness and poor chest rise. That's respiratory failure. Occurs when the blood is inadequately oxygenated or ventilation. Ventilation is inadequate to meet the oxygen demands of the body. The ultimate result of respiratory failure, if not corrected, is the patient is going to go into respiratory arrest. And we know what respiratory arrest is. Mr. Powell, mute your mic. Pay attention to your mic, people. I don't want to be stopping to mute people mic. So pay attention to your mic. Right? So that would be your reading assessment. So the first phase of your primary assessment is a general impression of the patient and the environment. Then you will approach your patient, ascertain the patient's level of consciousness using your AVPU. Based on the findings for your AVPU, you will either start off by assessing the upper airway or lower airway. And to assess the upper airway position, you check if it's clear, you look, listen, feel, full stop. For the lower airway, you assess rate, rhythm, quality, and depth. Based on the findings of the upper airway, if you assess the upper airway and something is wrong, then you need to think about maintaining positioning, and that is going to incorporate airway adjuncts. And then you need to determine that you need to breathe for the patient. And usually, you're going to incorporate airway adjuncts once there's a ventilation issue. If there's no ventilation problem, no airway adjunct is required. When you're assessing breathing, you will determine, based on the findings, if you need to give your patient supplemental low or high flow, or your patient need positive pressure with a supplemental oxygen source, right? And all of that will be based on your assessment. After you have completed your assessment of breathing, upper and lower airway, and fix any issues, then you can move on to circulation. With circulation, you consider mental status. So you consider the patient's level of orientation based on what the checks revealed in the LOC. You're going to evaluate pulse, you're going to evaluate skin condition. Now, in your circulation assessment, you must be considering blood loss, right? So you have to consider concealed bleeding. So assess the pulse. Now, if your patient is responsive, peripheral pulse. So if you have a responsive patient, you check the radial pulse. If the patient is not responding, then you go to the carotid pulse. So the pulse is a pressure wave that occurs as each heartbeat causes a surge in blood circulating through the arteries. Palpate, feel the pulse. If you cannot palpate a pulse in an unresponsive patient, CPR is needed, right? Now, skin condition. Now, before I go to skin condition, well, I'll talk about the pulse later on. When you evaluate the pulse, remember you're looking at the rate, the strength, and the rhythm. So is the pulse fast? Is it slow? does it feel normal, or is there a normal rate? Is it strong? Is it weak? Is it bounding? Is it thready? These are considerations. Is it consistent? For the skin, you're looking at the color of the skin. Are you looking at the palms of the hand? Looking at the mucous membrane. Under the eyelids, you're looking at the color of the lips. So once you can see changes peripherally, so if you're seeing discoloration peripherally, you definitely need to check for that centrally. So for skin condition, evaluate the patient's skin color, temperature, moisture, and cap refill. A normal functioning circulatory system perfuses the skin with oxygenated blood. Skin color, determined by the blood circulating through vessels and the amount and type of pigment present in the skin. Poor circulation will cause the skin to appear pale, white, ashen, or gray. All of these indicate poor circulation. So pale skin, white, ashen, or pale and white skin, you want to think about circulation issues there. Ashen can be circulation as well. When it starts to get that gray or bluish discoloration, then you start to think about oxygenation issues. So there will be peripheral vasoconstriction before you start to see cyanosis. So cyanosis is a late findings. That's not a good sign if you're seeing cyanosis. So skin color. When blood is not properly saturated with oxygen, it appears bluish. Changes in skin color may result from chronic illnesses or illness. You also will evaluate skin temperature. So at this stage in your circulation, it's not important a definitive number at this point. You will definitely be doing an accurate temperature reading in your vital signs segment. But at this point, it's not necessary for you to determine the exact temperature of the skin, right? What you need to determine, does this patient feel warm, hot, or cool? Or cold, right? That's what is important. We want to identify signs of shock or signs of a heat emergency or infection. The exact temperature at this point is not that important, especially when we're trying to identify live threats. Normal skin will be warm to the touch, 98.6 degrees Fahrenheit, and that number might change a couple of years from now, right? I think based on the research that's going on, you're going to see a normal core temperature of less than that. So there are research being done now that suggests that the normal body temperature is actually lower than that. So an abnormal skin temperature or hot, which can indicate a infection or inflammation process, can be cool, which can indicate shock. It can be cold, which can indicate hypothermia or shock. It can be clammy. Clammy means the skin feels sticky or lumpy, right? That's definitely poor circulation going on. So skin moisture, dry skin is normal. It should be warm and dry. Skin that is wet, moist, or excessively dry and hot suggests a problem. The cap refill, no, the cap refill is not an assessment you will primarily do on your adults. You can, but it's a more reliable assessment in your pediatric population. Capillary refill evaluated to assess the ability of the circulatory system to restore blood to the capillary system. Press on the patient's fingernail, remove the pressure. So you're going to squeeze the blood out of the capillaries in the nail bed, and it should develop a pale color. When you release, it should take less than 2 seconds to get back that pink color. If it's delayed, there's a circulation problem. So squeeze the nail bed until it gets pale. Release. Should take less than 2 seconds to return to its normal color. All right, now assess and control external bleeding. Right? Now you may end up doing this before or after your pulse evaluation. It depends on what it is based on the patient presentation. If you have addressed airway and breathing, you can quickly scan the patient for bleeding. If you find any areas of blood loss, instruct personnel to control that. Or it can be you assess the pulse immediately after the breathing and then control blood loss that's not considered significant. So assess and control external bleeding in trauma patients. Should occur before addressing airway or breathing concerns if there is signs of excessive blood loss. Bleeding from a large vein is characterized by steady flow of blood. Bleeding from an artery is characterized by spurting flow of blood because it mimics the contraction of the heart. And arteries are under high pressure, veins are under low pressure. Control external bleeding can be simple. It can be apply direct pressure. It can be you may have to use a tourniquet based on your protocol, right? So you will be guided by your protocol. There are some services that are experimenting with or doing research around TXA, a medication, to help in the clotting process. It's not standard in EMS management as yet. There are some services that are experimenting with hemostatic agent. It is definitely being used in the army, but it has not filtered down to civilian EMS as yet. It is something that might be incorporated in the future. Direct pressure is not, so you will consider a tourniquet if direct pressure is not quickly successful, obvious arterial hemorrhaging of an extremity. So do not apply a tourniquet if you don't know to do it properly. Right? So if you're not within protocol, meaning you don't have a protocol for it, don't do it. If you do not know how to do it, and when I say you do not know to do it, I mean you watch a video, you see it up on TV, somebody take a belt and tie around them arm, you shouldn't be doing a tourniquet, right? So in the States, it's within your protocol. Once it's within the protocol, the medical director will outline the various methods that you can use because there are various ways to do it. Then you have to go in a classroom setting where you practice the technique and the medical director evaluates your competency and then say, yes, you are allowed to do this in the field if it is necessary. Now, in the States, they have what is referred to as Stop the Bleeding campaign or courses. And basically what that is, it's a course that teaches civilians how to control bleeding and put on a tourniquet. It's like a course that mirrors BLS. There's a bleeding and management course. You're certified. And the reason why that's a movement in the States now is because of the mass shootings and the high incidence of penetrating trauma involving gunshot wounds, right? It is something that we here in Jamaica need to think about because the average Jamaican that is involved in trauma will not see the inside of an ambulance, right? The average Jamaican that gets a gunshot wound or a stab wound is not going to see the inside of an ambulance. They're going to be in a taxi or a civilian vehicle, right? And that's how majority of them end up at the hospital, especially in Kingston and Spanish Town and Mobile. Rarely these patients are going to see the back of an ambulance. Yes, Mr. Johnson.
Yes, sir.
Mm-hmm.
Yeah, I think so, boy, a full time we in a Jamaica, most of them places where me go or travel outside of the country, where them have the fire service and the police station. Sometimes all three of them they in the same place. So once one vehicle move, well, all three of them move when they move.
I agree. That's the stage that we need to get to. So I am with you on that.
Full time I know because I tell you, say, this is over 10 years when me travel. That means a long time before that I go on.
Right. Right.
So the taxi or a van back or something, that don't really work out, time because the most time where they need have a vehicle for respond because me used to do like we try to do some response training for ambulance and we like forget the timings of that take for leave from camp to go KPH or from camp to UE.
Yeah.
So I work out a time thing. So I always have them kind of training there.
That's good. But the issue, well, not an issue. The thing is, because to be honest, should I say this? Yes, I will. To be honest, if I should compare all of the response systems that are currently on the island, I would have the most confidence with the JDF response, right? So that's where I would have the most confidence, meaning if something happened to me, I'm going to see a JDF ambulance, I might not worry that much, right? And because as much as there might be challenges in the JDF response system, there is some guidelines that you guys follow. Now, the thing is, majority of your responses is specific to the JDF personnel, right? It's not much of that is available to the general population, right? Because the JDF have their own way of operating, and it's really for the JDF personnel. Outside of that, in Kingston, we don't have a ambulance that's tied to the fire brigade. So we don't have an ambulance tied to the fire brigade. We only have private available. Yes, Mr. Johnson.
Well, we do respond to calls like Crossroad. If something happen at the first place, it's them call camp.
Okay.
One of that little general area here, down on South Camp Road, or any little thing, out airport, in a camp here, they always call.
Okay.
Same
And you
thing
guys
with
do medevac transport as well, right?
yes.
Likewise,
right.
money too, sir. Money go operate the same.
Okay.
Yeah.
That is good. So the JDF is who I would put my money on. And after 20 years of EMS being established in Jamaica, I shouldn't have to be wondering which system would provide me the best treatment, right? It shouldn't be like that. But sad to say, the poor or the minorities of our society are the ones that are constantly injured. These are the people that are getting all of these medical emergencies and traumatic emergencies. And when it comes to trauma in the areas where we have minorities, they will not be calling on a EMS system. They're going to put people in the back of vehicles, and they might be put, the person might have penetrating trauma, and all they're doing is just driving with the person, and the person is bleeding out. I've seen a video of that where I think the person was either shot or stabbed, and the guy had the person in his arms, and him, all he must say is down there, and he's bleeding. The person is bleeding out, right? So I think we need to, and it has to start with public education. So that's where it has to start. It has to start with public education. They need to be educated in terms of what they are entitled to as citizens of Jamaica. And then same way as how the Ministry of Health launch a campaign to educate the public about COVID-19 and wearing masks and social distance and all of that. They can put that same effort into EMS awareness and teach the people them how to control bleeding. Because we have a lot of trauma here. We do have medical emergencies too. And I mean, these persons are coming in vehicles, but there's a higher risk with trauma, because if there's suspected spinal injury and just pick up somebody and fling them in at the back of the unit. Come on. There was an incident where there was somebody involved in a motor vehicle accident, and unseen, she was able to open her door. So she was able to open her door and maneuver her limbs. When the people them drag her out of the vehicle and she reached a UE, she paralyzed. She was paralyzed, right? So there are serious consequences. Yes, Mr. Johnson.
All right. In regards to whole ambulatory EMS system in Jamaica, something where a long time really I look back on it and really wonder if the persons them who drive most of the ministry ambulance, especially in the hospital. All them know if we do is drive from point A to point B, push a wheelchair or take out one stretcher, put somebody upon it. So if you call one hospital, forget one ambulance to come pick you up at your yard. Sometimes I just the porter and the driver alone come.
You are correct. You are correct.
You're
very much
so,
correct.
You understand? They come like it's a hearse. They said come for your body.
You are right. And you have to be selective in terms of which hospital you're going to call, right? So you have to make sure that that hospital have EMTs there, and it's not every hospital in Jamaica have that. So you're just gonna get a porter and maybe a practical nurse if you're lucky. Yes, Mr. Manning.
Yes, sir, as Mr. Johnson mentioned that, sir, because I found it strange before the whole class and program and stuff, I went to a few hospitals, to speak with the EMTs to get a feel of what I'm getting myself into.
Yes.
And the persons in the ambulance, and I'm asking, so I went to the gentleman and I said, oh, so you're the EMT, right? And I'm just assuming. He said, no, I'm a porter. So I say, porter. Porter, the persons were just, so I say, so who else is like on it? So it's like 3 of you guys on the ambulance. I said, no, it's the driver and him. And that's normally how they do. And I had to search. I think there was one person who was in charge, was an AEMT. But everybody else was just a driver and a porter.
Which hospital?
specific one was Cornwall Regional. I think they have EMT. It just probably a bad day I went. I don't know what happened that day. But
I think Parno EMTs, you know, I believe they do. The question though is there accountability? And when I say is there accountability, are they working under direction? Are they up to date? Yes, Mr. Wilson.
Sir?
Yes.
Well, I don't want to call a specific name of the hospital still, but at one point I was on duty and there was a patient that came in that a vehicle hit him down, but the vehicle carried the patient come to the hospital. And when the patient was supposed to come out of the vehicle, they were lifting him from his hands and foot. However, looking at that patient at that time, I saw where he had an head injury because all of his head was totally burst up and everything, and his feet all over him was burst up. And I said, why are you all lifting him like that? Why don't you all try to like get a stretcher to put him on it? They must say, no man, just we just have to take him out right there, so no one just put him on it something like that. Aside from that, me no put my chest in the hospital again. Well, I went there a few times again where I was sick, but I don't think I put my chest in that hospital.
Okay. On that note,
Wilson.
on that note,
Wilson.
hold on. Terrell,
Wilson.
mute your mic. Mute your mic.
So Wilson,
Mute your mic.
I'm actually saying something there.